S.T.O.P ROP, Stop ROP, the 2020 Consensus Statement on Retinopathy of Prematurity Prevention and Screening in the Philippines will start in a few minutes.
Sa panahon ngayon, ano ang alagang Pilipino? Ito ay alagang hindi makasarili. Alagang laging gumagawa ng paraan. Alagang nagkakaisa para sa bawat isa. Alagang handa sa anumang hamon. Alagang ramdam kahit saan ka man. Alagang maaasahan. Alagang nagbibigay ng solusyon at mga ngiti. Alagang busog sa pagmamahal. Yan ang alagang Pilipino. Alagang may husay at malasakit. Alagang nagbabayanihan. Nakikiisa ang Unilab sa lahat ng Pilipinong walang sawang nagbibigay ng alaga para sa kalusugan ng bayan. Alagang tunay, alagang Pilipino.
Welcome to Stop ROP, the 2020 Consensus Statement on Retinopathy of Prematurity Prevention and Screening in the Philippines. This online event is brought to you by the Philippine Pediatric Society, the Philippine Society of Newborn Medicine, the Philippine Academy of Ophthalmology, and the Retinopathy of Prematurity Working Group of the Philippine Academy of Ophthalmology. In partnership with Alagang Unilab and Pediatrica. Now, just a quick reminder to our participants, just one guideline. Good afternoon, everyone. You are currently view only, so please expect your microphones to be on mute during the entire presentation. Welcome once again, doctors, to Stop ROP, the 2020 Consensus Statement on Retinopathy of Prematurity Prevention and Screening in the Philippines. We hope you are all doing good today, and thank you for giving time for this discussion. To formally begin the webinar, let us take a moment to say a prayer that will be led by Dr. Ao Libadia, the Chair of the Committee and Advocacy, also Board of Trustee of the Philippine Society of Newborn Medicine.
Let's put ourselves in the holy presence of the Lord. In the name of the Father, and of the Son, and of the Holy Spirit. Amen. Heavenly Father, thank you for this day and for all the blessings you've given us. Thank you for giving us the opportunity to hold this webinar on the 2020 Consensus Statement on ROP Prevention and Screening in the Philippines. We are truly grateful for all the hard work of the team and the different partner societies in developing this consensus statement. We are also thankful for all the organizers, speakers, moderators, and sponsors in making this webinar possible. We humbly ask you, Father, to shower speakers and moderators with great inspiration so that they may share the most of their knowledge and impart the updates and best practices in ROP prevention and screening. Open our minds and hearts that we may retain the invaluable learnings that we gain in this webinar and put them into practice to be able to serve our patients better. Help us to work together and encourage each other to achieve our goal in reducing the incidence of ROP in the country, as well as providing better quality of life for our preterm patients. We pray for enthusiasm, compassion, and dedication of all those involved in pursuing this advocacy. During this time of pandemic, we also pray for the healing and full recovery of all those afflicted by the COVID-19 virus. And we pray for our friend, Dr. Karen Senen, as well as strength and guidance for their loved ones. We also pray for all of the attendees of this webinar, all the frontliners, and our families and friends. Please continue to bless us and keep us safe and healthy. Grant us with your divine wisdom as we perform our daily activities, and give us the desire to continue to improve ourselves to be able to offer the best care for our patients. Continue to remind us that all we do and accomplish is for the service of the people and for your greater glory. We offer to you everything, Father, for without you we can achieve nothing. All this we ask in your most holy name. Amen.
Now we will not make you wait any longer. To help us facilitate today's discussion, let us all welcome the following doctors who will moderate the session. Dr. Alvina Pauline Santiago and Dr. Maria Conchitina Bandong. Good afternoon, doctors. The virtual stage is now yours.
Good afternoon, everyone. To the 840 attendees for this special event, it is my pleasure to be one of the moderator for this afternoon's activity. To officially start, let me call on the President of the Philippine Society of Newborn Medicine to give her opening remarks. Let us all welcome Dr. Belen Amparo Velasco. Dr. Velasco, the floor is now yours for the opening remarks.
Okay, good afternoon, Dr. Jocelyn Eusebio, Dr. Margarita Kathleen, Dr. Pearl Tamesis Villalon, colleagues, friends, and everyone. I would like to welcome you to this event, which is very memorable for us, for in this consensus statement, we were able to achieve the goal of developing a collaborative, coordinated, and cost-effective strategy to address retinopathy of prematurity in the Philippines. And we considered the different areas and the deliberations among the stakeholders. So it is a fitting update on the consensus statement that was done in 2013, and now that was we have already 2020, which is based on studies here in the Philippines, as well as review of literature. So Once again, I welcome everybody to this consensus statement launching. Thank you.
Thank you, Dr. Velasco. We are very much honored this afternoon to be graced by the presence of the President of the Philippine Pediatric Society to give her special message for this event. Let me now call on Dr. Jocelyn Alonso Eusebio.
Thank you very much. Good evening to everyone and welcome to S.T.O.P ROP, the 2020 Consensus Statement on ROP Prevention and Screening in the Philippines, jointly hosted by the Philippine Pediatric Society, Philippine Society of Newborn Medicine, and the Philippine Academy of Ophthalmology ROP Working Group. I laud this event because retinopathy of prematurity is one of the few causes of childhood visual disability and avoidable blindness. As a pediatrician, especially one working with children with special needs, I know how greatly visual impairment or blindness can impact a child and his family. I am therefore grateful, and on behalf of the more than 6,000 members of the Philippine Pediatric Society, I thank everyone who worked tirelessly to have this project come into fruition. I convey my appreciation especially to Dr. Maria Belen Amparo Velasco, the President of the Philippine Society of Newborn Medicine, Dr. Margarita Lat Luna, the President of the Philippine Academy of Ophthalmology, and Dr. Pearl Tamesis Villalon, the Chair of the PAW ROP Working Group. To this afternoon, we are privileged to have a distinguished roster of speakers, and we thanks to all of you who for your selfless service to the Filipino children. Our gratitude is likewise extended to our industry partner, Unilab. In the midst of the crisis that envelops us, we should not lose sight of one of our most important responsibilities. That is to help prevent and alleviate ROP. After all, every child should have the chance to have the vision of a great future. Again, my warmest welcome and thank you to all of you who are with us again this afternoon.
Thank you, Dr. Eusebio, for a very heartwarming message. I will now turn over to my co-moderator, Dr. Pauline Santiago, to introduce the next personality who will give her special message. Over to you, Pauline.
Thank you very much, Dr. Bandong. Oh, my internet connection is unstable. Okay, let me introduce Dr. Pearl Tamesis Villalon. She is a vitreoretinal specialist consultant at the St. Luke's Medical Center. She is our chair, very hardworking chair of the Retinopathy of Prematurity Working Group of the Philippine Academy of Ophthalmology. The ROP Working Group is now a subcommittee of the Community on Community Ophthalmology of the same organization. She was a previous president of the PAO, and she's now the vice president of the Philippine Board of Ophthalmology and the chair of the accreditation committee of the same board. Ladies and gentlemen, Dr. Pearl Tamesis Villalon.
Good afternoon, everybody. Let me, as my message, tell you a bit about history of this group, this advocacy, just for 3 minutes. Way back in 1999, the International Agency for the Prevention of Blindness, the IAPB, during its launch of Vision 2020, already identified ROP as an upcoming concern in the group of childhood blindness. It is now 2020. Several countries, of course, took up the challenge, but not many. During all the years after 1999, some colleagues and I began receiving patients who were blind from the late stage of ROP. Dr. Pauline was one of them. Dr. Pauline, that tells of our age, okay? I'm older than you. But anyway, these referrals were from ophthalmologists, pediatricians, and many were walk-ins. It was truly disheartening to see a baby who you could not help. And you right away knew that this baby was sentenced to a life of darkness, misery in darkness. All right, then after that, you know, things are working in our minds, what we do about it. But fortunately, there was a meeting called by Orbis, the flying hospital in Guangzhou, of 5 Southeast Asian countries, and they wanted to see what was being done about ROP. And we were one of the countries, and you know, the 4 others had programs in place, and we did not. They had programs, the struggling programs, that was okay because it was there, but we did not. So when we came home, there was a scramble to look this up and do something about it, and hence the establishment of the ROP working group. We reached out to the ophthalmologists, of course, the pediatricians, neonatologists, even the lay people, the parents of those kids who had ROP. And of course, there were personalities who also came to us wanting to help. And of course, you know about Apple, the app of the Black Eyed Peas. He donated 2 red cams, the wide field cameras, and a laser to SPMC and JB Lingard. And I think 3 are still in the pipeline, and he will do more for us to help us with this. That just shows you how much interest was generated by this simple action of establishing a program. And as you see now, this afternoon, there's the consensus to sign, consensus statement to sign. And this is a group work. It's a wonderful accomplishment for pediatricians and ophthalmologists, and especially for our babies. Let me also tell you that our battle cry in ROP WG is 1 blind baby is 1 too many. We understand that the incidence is very small. The numbers are small. If you just look at the numbers, it's minuscule. But think about this. A blind child has to live a life, a miserable life from blindness, from infancy to about maybe 60, 70, 80 years of age. Who wants that? No one. Then think about the parents and other people who have to care for this person. And this disease is avoidable, to top it all, if caught early and intervention is done at the right time. So with that as a backgrounder, I welcome everyone to this special event. It is truly a momentous event, a meeting of minds to help our babies. So sit back and relax and let all this information come into your minds this afternoon. Then after that, please help us in our advocacy. Thank you very much.
Thank you very much, Dr. Villalon, for a beautiful story of the ROP working group and coming up with an ROP screening protocol. Okay.
Thank you, Pauline. We shall now proceed with our lectures. Let me briefly introduce our first speaker. He is the committee chair of the ROP and Philippine Society of Newborn Medicine. He is a fellow of the Philippine Pediatric Society, and he is an active consultant in Makati Medical Center. So let us all welcome Dr. Victor Sapanta. Over to you, Dr. Victor.
Hello, good evening. Do you hear me? Everybody? Hello.
Yes, sir. Loud and clear. Loud and clear,
Okay.
Dr. Victor Sapanta. You may proceed, sir. Go ahead.
Okay, so let's see my first slide. Okay, good evening, everybody. Thank you to the leadership and working group of Philippine Society Newborn Medicine Philippine Association of Ophthalmologists, Philippine Pediatric Society for allowing me to participate on this momentous event. A special note of congratulations and thanks to Dr. Ao Libadia, our PSNB advocacy chairman, which involved me in this project, and to Dr. Iya Monson, the PAO ROP working group member, which I admired their valuable works and commitment on this team project with the subsequent release of this ROP Philippine Preventive Care Plan Strategy Statement, of which we had this consensus statement and preventive program on ROP. The title of my talk is 100% Not Good Enough, S.T.O.P ROP. I have 25 slides, and hopefully I can tackle this topic with allowable time. This slide has the Arizona nostalgic sunset and the saguaro cactus in the forefront, where I pulled in the experience with my 30 earlier years of neonatology practice to share with you this presentation. Clarification on the jargon on this presentation. 100% refers to oxygen saturation by oximetry device. S.T.O.P ROP refers to larger premature infants that experience severe sepsis in the neonatal ICU. That is for S. PAC RBC transfusion within the first 10 days. For T, oxygen exposure, especially without oxygen blender. For O, and prematurity with unstable stormy clinical course, and that's P. And our working group has dubbed this program as S.T.O.P ROP for quick recognition. Of note, there is an earlier S.T.O.P ROP praise in 2000, which referred to a RCT study referring to supplemental therapeutic oxygen by pre-threshold ROP. This slide highlights in the UNICEF neonatal mortality data for the Philippines in 2015. And this slide shows you prematurity as the #1 cause of mortality, followed by perinatal asphyxia, then congenital anomalies, and neonatal sepsis. Of note, neonatal sepsis has decreased dramatically in the past decades because of the pioneering work of Dr. Asuncion Silvestre on the Unang Yakap project, also known as the Early Intensive Newborn Care, EINC, which is now a standard practice in the Philippines and developing countries. Along with the joy and pride of taking care of premature babies comes along with concerning morbidities like chronic lung disease, commonly known as BPD, intracranial injuries with intracranial hemorrhage and periventricular leukomalacia, with subsequent neurodevelopmental disabilities, and ROP with associated ROP blindness. of which was reported in our local studies of 15% prevalence in Metro Manila of surviving prematures. ROP key concepts. This disease is a complex, dynamic, multifactorial disorder. In other words, it's not a simple, straight disease process. The main great causes is associated with prematurity with low birth weight, the NICU environment, along with the severity of the premature illness in the context of oxygen exposure. With that H&H events, hyperoxia, hypoxia episodes. This disease is a vasoproliferative disorder of retinal immaturity with factor dysregulation. It is highlighted with vascular changes seen around the 3rd, 4th week postnatal age or around 31, 34 weeks postconceptual age and evolves up to 44, 48 weeks postconceptual age. ROP, as the name implies, is a disease of premature infants. Infants with unique characteristics like incomplete retinal vascular development, with fetal in utero, the fetus thrive on a PO2 of mid-20s or saturations of mid-50s, 60s, and at birth with fetal hemoglobin, newborns sufficiently thrive on a PO2 of 45 with an equivalent saturation of around 85. Of note, tissue oxygen delivery is partly dependent on your PO2, partial oxygen pressure, but mainly with oxygen content of hemoglobin, blood flow, and the well-forgotten but important hemoglobin dissociation card, which I will further discuss in later slides. This slide highlights the ROP pathogenesis schema. And if you will see here, in utero, as I mentioned earlier, thrives at PO2 of mid-20s or saturations mid-50s, 60s, and with premature birth with relative hyperoxia and sustained hyperoxia, decreased VEGF production with cessation of the retinal vessels, which initiate the ROP process. With sustained hyperoxia and hypoxic spells, there is VEGF dysregulation or increased VEGF productions that influence retinal neovascularization that had fires to this pathology process. Stage 2, stage 3, in phase 2 disease process. And hopefully, with timely detection and screening and timely intervention, we can prevent the complication of this disease process to go to stage 4 and 5 with retinal detachment and tragic blindness. And you can see here the prematures that are high risk of this disease between 22 to 30 weeks weaker, and the appropriate timing of around 31, 34 weeks, and the disease process evolves around at this time. ROP epidemics. Now in our midst, we have the SARS-CoV-19 pandemic. which is much broader and serious than the ROP epidemic and comes in waves as we are warned with this COVID pandemic. The first wave of ROP epidemic was noted in 1950s with routine, unregulated use of oxygen supplementation to newborn, which highlight the first epidemic known at the time RLF, retrolental fibroplasia, the old name for ROP. And this disease was abruptly abated with dramatic curtailment of unregulated oxygen administration in the newborn. The second wave of this disease was seen in the late 70s and 80s. When I started my neonatology training and early neonatal project, I experienced this at first hand, this disease, with increasing neonatology, with evolving neonatology practice and technology and understanding of the science, we're able to survive these very sick premature infants. And the third wave, please come back. Yeah, third wave in 2000, late 1990s, with further improvement in neonatal care. There is the improvement or the survival of very sick premature infants, and more so the larger prematures that fall out on the standard routine ROP screening criteria. Next. Some reason for the third wave, which we are trying to address in this meeting. As in our country, we have these suboptimal resources. There is this varying clinical practice in every part of the country and institution. Of course, with our improving neonatal care, there is again the increased survival of these sick premature infants. But I think the elusive reason is the evolving oxygen supplementation and monitoring practices, which I'm going to talk a while with this short presentation. Next slide. Again, this meeting goal is to decrease ROP prevalence and its associated blindness complication. ROP is the leading cause of childhood blindness in the Philippines, as from our local sources. And the standard ROP screening was again less than 1,500 grams or less than 32 weeks premature. And with this rising epidemic, as has been mentioned by the previous speaker, in 2013, the PAO ROP working group recommended a higher screening standard for bigger prematures. Next slide. So how can we dissect this clinical dilemma, whether to screen or not to screen these larger prematures? So let me give you clinical scenarios which are common in our clinical neonatal practice. Patient A, 30-weeker, 1,000 gram, needing nasal CPAP and oxygen. Patient B, 33-weeker, 1,600 gram, C-section for maternal hypertension, given prenatal steroids, and experience minimal oxygen for 24 hours. And patient C with the same clinical condition or data on patient B, 33-weeker, 1,600 gram, but a start C-section due to severe eclampsia. So no prenatal steroid. The premature experienced high membrane disease, needing CPAP or mechanical ventilation, and sometimes surfactant treatment, and exposed to oxygen for around 2 weeks. And patient D, bigger premature, around 34, 35 weeks, 2,200 grams, with preterm labor, PPROM, neonatal pneumonia, pulmonary hypertension in the newborn, remarkable mechanical ventilatory support and oxygen, PAC-RBC transfusion needed to keep this baby alive out of the NICU. Next slide, please. So with ROP risk profile stratification, the back-end approach with a timely ROP screening strategy, all these 4 babies will fall in for the screening criteria. But with this 2020 ROP PPCP strategy, with an integrative approach of proactive preventive intervention and timely screening program, patient A, patient B, C, and patient D will fall out or fall in for ROP screening criteria. And patient B with low risk profile may not need a routine ROP screening. Next. So with this 2020 ROP PPCP strategy, risk factors for ROP screening, all newborns less than 32 weeks gestation or less than 1,500 grams, and some newborns between 32 to 36 weeks gestation with risk factors of S.T.O.P. S for severe sepsis, P for PAC-RBC transfusion, O for oxygen exposure, especially without O2 blender, and premature with stormy, unstable clinical course. Next. So this American Academy of Pediatrics policy statement on screening examination for ROP states that all infants, this is in the US, less than 1,500 grams or less than 30 weeks gestation. By the way, this was just released in 2018. And also selected infants with birth weight between 1,500 to 2,000 grams or gestational age greater than 30 weeks with unstable clinical course, like hypotension requiring inotropes, oxygen supplementation for more than few days, receive oxygen supplementation without saturation monitoring. And again, this recommendation is for US and mentioned for other countries could have different screening parameters. Next. Next. Oxygen, about oxygen supplementation. Joseph Priestley established the necessity of oxygen for life in 1600. And we as neonatologists recognize oxygen supplementation is vital for the care of our critically ill preterm. But at the same time, we are now recognizing that uncontrolled oxygen use has unintended consequence. In the early 80s, in my training, the usual monitoring of oxygen is through transcutaneous PO2 or blood sampling through umbilical lines or peripherals. But because of complications and difficulties, these techniques were overshadowed by pulse oximetry, which provide easy continuous estimates, again, an estimate of arterial oxygen saturation, and recognize as that they have several practical, technical, and physiological limitations. Next. Arbitrary and not absolute ceiling to minimize ROP is PO2 below 80 millimeter mercury, and that is equivalent to around 95. So the optimal oximetry saturation for premature is around 85 to 95. And for bigger babies, to reduce pulmonary toxicity, it will be around less than 100 or 98%. Next slide. So this is the notable hemoglobin oxygen dissociation curve, which is a great influencer of tissue oxygen delivery. On the first graph here, shows you the comparison between fetal and adult curve. And of note, by the way, this curve is the correlation between oxygen saturation to PO2. And you could see this is not linearly correlated. It is S-curve. So what does this mean? That above 95 saturation, there is a poor fit correlation with PO2. There could be a wide range of PO2, which is potentially toxic to the developing premature retina. This slide shows you the shift to the left, shift to the right that influence this dissociation curve. Like PAC RBC transfusion, shift the curve to the right, decreasing oxygen affinity, so increasing oxygen unloading, increasing the risk of ROP in the other context of complications. Next. So we have to develop a oxygen supplementation monitoring policy to minimize and prevent this dreaded disease. And the goals are, again, limit unnecessary use and administration of oxygen, minimize abrupt changes in the FiO2, avoid periods of hyperoxia, more than 93 or 95 in specific premature babies, and prevent large swing in O2 saturation. Next. So this is the American Academy Pediatrics clinical report in 2016 of oxygen targeting in extremely low birth weight infant, wherein they states that ideal physiologic target range is patient specific and again dynamic. Recent RCT suggests targeted SpO2 of 90 to 95 may be safer than 85 to 89, balancing the negative and positive outcome. Alarm limits are to be used to avoid potentially harmful extreme of hyperoxemia or hypoxemia. And this clinical report also discussed the benefits and limitation of pulse oximetry and summarizes the 4-5 RCTs on oxygen to saturation targeting. This RCT, one of them is the S.T.O.P ROP, BOOST 1 and 2, support and COT studies. Next. Next. So what is the goal of this oxygen monitoring policy? The goal again to avoid hyperoxia, hypoxia episodes. Target saturation is around 90 to 95, and I think this is an has been somehow resolved in the past 10 years of some clinical studies. Alarm limits between low limit of 85 and 96 above limits with a reliable, accurate oximeters. And now they're also talking smart oximeters. And with strict implementation of an O2 policy with an educational trust. Next. Next. As they say, the devil's in the details. So more in the details. FiO2 should be weaned by slowly by 2 to 5% at times if O2 saturation is on the high side. The delivery room, wean FiO2 rapidly to avoid saturation above 93. Oxygen saturation guidelines should be fully understood and strictly implemented. And oxygen should be recognized as a drug with adverse event in preterm infant. Next. Next. So this is a UCLA Cedars-Sinai Medical Center experience on enforcement and implementation of oxygen policy of more than 450 surviving prematures from 500 to 1,500 grams from their 5-year studies from 1997 to 2001. And in this study, they found out that there was a significant decrease rate of severe ROP in very low birth weight infants from 12.5 to 2.5%. And they also noted that there is a wide intercenter variability of severe ROP from 4 to 18%. They also noted and expanded that visual prognosis of children with threshold who reach threshold this ROP is poor despite current intervention. So reducing threshold disease is an important goal to avoid unfavorable visual outcome. Next. Next. ROP preventive strategy should be multi-sectoral and must be approached from different levels and aspects of care, like legislation, certifications of hospitals or NICU, basic equipments needed, O2 blenders, CPAP device, and oximeters, which are affordable and cheap as compared to million pesos ventilators. Of course, some NRP standard guidelines, KMC, and basic medications, surfactant, though expensive, and some challenging situation, and caffeine citrate, a cheap drugs, and has been long established for many years in the developed world that need to be available and accessible in the Philippines and in our NICU. Next. Next. So the take-home message, let's adopt the 14-point recommendations of the 2020 ROP PPCP strategy. ROP and associated blindness is a complex and a dynamic disease, but an unavoidable illness. For me, less is best in premature care. Less O2 by utilizing O2 blenders, nasal CPAP, and caffeine citrate, along with a strict O2 supplementation monitoring policy, maintaining a saturation of 85 to 95%. Next. Next. 100% oxygen saturation approach in premature care is not good enough, and it is a harmful practice. A holistic approach strategy is highly needed to manage this devastating illness and prevent threshold disease. And a stratified ROP screening program is desirable and be based on local experience and resources. Next. Good night, God bless, and be safe. Thank you.
Okay, thank you very much, Dr. Zapanta, for that comprehensive lecture. Let me introduce our next speaker, our colleague, Dr. Iya Monzon Pajarillo. Dr. Pajarillo is a diplomate of the Philippine Board of Dr. Pajarillo is a diplomate of the Philippine Board of Ophthalmology. She is a fellow of the Philippine Academy of Ophthalmology and a member of the Society of the Pediatric Ophthalmology and Strabismus. She also practices adult comprehensive ophthalmology and microsurgery. She finished her clinical and surgical fellowship in pediatric ophthalmology and strabismus at the Rotterdam Eye Hospital, and the Philippine General Hospital. She also finished her residency training at the University of the Philippines, Philippine General Hospital. Ladies and gentlemen, Dr. Andrea Cristina Monzon Pajarillo.
Okay, good afternoon. I am happy to present to you today the product of a joint effort between pediatricians and specific to preterm babies. It is only appropriate that strategies to address it are planned together by both our specialties. The ROP Philippine Preventive Care Plan Strategy is a consensus statement of the Philippine Society of Newborn Medicine and the ROP Working Group of the Philippine Academy of Ophthalmology, supported by our mother societies, the Philippine Pediatric Society and the Philippine Academy of Ophthalmology. These are the sections of our consensus statement, which I will discuss in this presentation. So why does ROP deserve our attention and concern? It has been identified as an important cause of avoidable childhood blindness globally. I'd like to bring your attention to the words avoidable and childhood blindness. I place emphasis on avoidable because we can do something about it, we can prevent it, and it doesn't have to happen to a child. And childhood blindness is something we would never want to happen because it condemns the child to a lifetime of disability and limitations. ROP has been around for decades, but we are seeing some changes, especially in moderately and poorly developed countries where bigger and more mature sick babies are getting ROP. Locally, despite the lack of a national registry, hospital-based data have shown ROP to occur in up to 15% of preterms in Metro Manila. Briefly, ROP is a retinal vasoproliferative disorder where all the damage occurs in a baby's inner eye. On gross examination, these babies appear to have normal eyes, but when you look inside, you can see any of one of these 5 stages of ROP, ranging from a delineated avascular area to total retinal detachment. Known risk factors for developing ROP are prematurity, low birth weight, coexisting illness, and its consequent management, which will be further discussed later. The title of this webinar is S.T.O.P ROP, which stands for the main risk factors that are highly associated with the development of ROP. These are severe sepsis, packed RBC transfusion within the first 10 days of life, oxygen supplementation, especially without the use of an oxygen blender, and prematurity with an unstable clinical course. It is hypothesized that the correlation between sepsis and ROP is from the direct exposure of the developing retina to circulating products of inflammation like various cytokines and from the production of reactive oxygen species due to oxidative stress. Transfusion with packed RBC during the first 10 days of life has been found to increase the risk of developing ROP up to 4 times. It is hypothesized that it is due to the rapid increase in adult hemoglobin in the baby circulation that causes a shift in the oxygen dissociation curve, increasing oxygen delivery to retinal tissue. The role of oxygen in ROP has long been accepted. The pathogenesis is believed to be from hyperoxia that arrests retinal vascularization in phase 1, followed by hypoxia from increased metabolic processes in the eye that causes pathologic production of vascular endothelial growth factor in retinal neovascularization. There have been 3 ROP epidemics in history. The first one during the 1940s and 1950s from unrestricted use of supplemental oxygen. The second one was during the 1970s to 1980s from increased survival of premature infants, especially in developed countries. The third epidemic started in the 1990s and continues until now in middle and low-income countries. This is from increasing prematurity rates coupled with suboptimal neonatal care. We are seeing bigger and more mature sick babies developing ROP. Two ROP guidelines have been published in our country. In 2005, the policy statement on ROP screening by the PPS, Philippine Society of Pediatric Ophthalmology and Strabismus, and the Philippine Society for Developmental and Behavioral Pediatrics adopted U.S. screening guidelines. In 2013, these guidelines were revised after a call from the international ROP community to develop region-specific guidelines. There was local evidence of bigger and older Filipino preterm babies developing ROP. Thus, the cutoff limits were increased to 35 weeks and 2,000 grams. Challenges encountered in the implementation of these guidelines were a lack of awareness among healthcare providers and parents, unequal distribution and availability of qualified screeners and ROP specialists, financial issues regarding ROP screening and treatment, and the need to balance between the risk and benefit of ROP screening and treatment, particularly in fragile babies. These issues have brought together the PSNBM and the PAO-ROP working group to collaborate with a goal of developing a plan and strategy to decrease ROP blindness in the country. We saw the need for communication and cooperation among stakeholders, the need to make guidelines in accordance with local scenarios of to work together on this problem. The consensus arrived at the following conclusions. There is a need for multi-sector coordination, including the Department of Health, PhilHealth, the PPS, PSNBM, PAO, and other stakeholders in addressing ROP blindness. Decision-making and responsibility lie on both healthcare providers and well-informed parents. Implementation of strict oxygen supplementation and saturation guidelines is key to prevention of severe ROP. A comprehensive, collaborative, coordinated, and cost-effective strategy must be developed to address ROP in the country. Prevention, early screening, detection, and prompt intervention are important in management of ROP. A standard ROP screening program must be adopted by centers providing advanced neonatal care. Necessary interventions and resources should be available at the NICU, at transfer units, and after discharge. And patients should not be discharged or transferred until a plan of care is in place and is documented with informed parents. The consensus arrived at multi-sector recommendations for care, which can be classified under prevention and early detection and management. Prevention falls under the domain of health institutions, hospital administration, obstetricians, pediatricians, and neonatologists, while the realm of early detection and management falls in the hands of ophthalmologists. Efforts from both sides are meant to stop ROP blindness. The consensus gives the following recommendations. First, to implement measures to decrease preterm birth and to use antenatal steroids from the obstetrician standpoint. Equip hospitals providing newborn care with devices for proper delivery of oxygen supplementation, such as pediatric flow meters, oxygen blenders, nasal, continuous positive airway pressure, and oximeters, and require these for DOH certification. Hospitals providing newborn care must be staffed with medical providers certified in newborn resuscitation in Philippine Setting Plus or NRPH Plus, and this must be part of the requirements for DOH certification. Mandatory maternal or neonatal transfer to a facility capable of the appropriate level of care when medically and logistically feasible. Post-delivery and NICU care must follow the NRPH Plus guidelines. Emphasize the use of oxygen blenders and use CPAP before ventilator support. Prevention and reduction of infection with essential intrapartum and newborn care or EINC and kangaroo mother care or KMC practices together with judicious antibiotic use. Caffeine citrate must be made available to control hyperoxia or hypoxic spells. Appropriate pulse oximetry devices for reliable reading with blood gas correlation if needed. Adoption of unit or regional target oxygen saturation set at 90 to 95% with alarm limit set at 89 to 96% coupled with a strict fraction of inspired oxygen supplementation policy. ROP screening is recommended for all newborns with gestational age less than or equal to 32 weeks and those with birth weight less than or equal to 1,500 grams. Newborns between 32 to 36 weeks gestational age with the STOP risk factors should also be screened. S stands for severe sepsis, T for transfusion with packed RBC within the first 10 days of life due to anemia, O for oxygen use, especially without the aid of an oxygen blender, and P for prematurity with an unstable clinical course as assessed by the attending pediatrician or neonatologist. Timing of initial ROP screening is recommended as follows. For preterm infants less than 28 weeks gestational age, initial screening is recommended at 31 weeks gestational age or prior to discharge, whichever comes earlier. And for preterm infants 28 weeks gestational age and above, screening is recommended at 31 weeks gestational age, whichever comes earlier. The reason behind this recommended timing is that examining very premature infants too early will not yet show evidence of ROP and will only place the baby at undue risk of the screening procedure. The usual recognizable progression of ROP is noted around 3 to 6 weeks postnatal age or 31 to 33 weeks gestational age. Follow-up examination will be as deemed necessary by the ophthalmologist depending on findings at initial screening. The follow-up schedule must be properly coordinated for patients who will be discharged. Recommendations to control the risk factors are as follows. During resuscitation, 30% oxygen should be used initially, then titrated accordingly based on recommended pre-ductal oxygen saturation monitored by pulse oximetry. 60 to 65% at 1 minute, 65 to 70% at 2 minutes, 70 to 75% at 3 minutes, 75 to 80% at 4 minutes, 80 to 85% at 5 minutes, and 85 to 95% at 10 minutes. We emphasize the use of pulse oximetry during resuscitation and administration of oxygen and judicious use of packed RBC transfusion. Use of human milk feeding to decrease the incidence of ROP is also recommended. As with any published clinical guideline or health policy, regular review is recommended since the population of infants at risk and the healthcare environment change over time. We recommend a review of our recommendations every 3 to 5 years. It is also important to conduct standardized prospective studies to validate and refine our recommendations, gather evidence, and to determine the most appropriate screening criteria for future guidelines. Supplemental infrastructures are needed to support our recommendations to address ROP in the form of public awareness, legislation, and strengthening of healthcare financing. With the advent of social media and the digital internet age, the public is now easier to reach. We have made some steps forward with regards to community awareness and response because now there are ROP mothers groups on Facebook, established around 2 years ago with 958 current members. We need to continue and further enhance this public awareness. With that, I end my talk. Thank you very much for your attention.
Thank you very much, Dr. Pajarillo. I think we will proceed to the next part of the event, Dr. Bandong.
Yes. Yes, Pauline, we shall now be moving on to the much awaited ceremonial signing. So I think we would like to request our 4 signatories. We would like to call back on Dr. Eusebio, the President of Philippine Pediatric Society, Dr. Velasco, the President of the Philippine Society of Newborn Medicine. And your end, Pauline? Your
Dr.
signatories from your end?
Yes, Dr. Margarita Latluna, the President of the Philippine Academy of Ophthalmology, and of course, Dr. Pearl Villalon, our chair at the Retinopathy of Prematurity Working Group.
Yeah, so we would like to call in these 4 for Dr. Lady, so we can proceed with the ceremonial signing. Are they on screen already, Pauline? Can you see them?
I'm waiting for Dr. There. Everybody's here?
Yes. Okay.
Yes, everybody's here.
Okay, I think the first signatory is Dr. Jocelyn Eusebio, the president of TPS.
Okay, I cannot see Dr. Luna. Okay,
Yes,
there's
Dr.
Dr.
Eusebio,
Eusebio.
can you please? Okay. She will do the actual signing of our consensus statement guidelines. Okay, thank you very much, Dr. Jocelyn Eusebio. Let me now call on, I think it's the Philippine Academy of Ophthalmology President Pauline, who is the next signatory. Can you see her?
No, I don't see Dr. Luna. Dr. Luna?
Yeah, there she is.
There's
Okay.
Dr. Margarita Luna,
Okay.
president of the PAO.
Yes. And our next signatory, if I'm not mistaken, is the president of Philippine Society of Newborn Medicine, Dr. Velasco. We would now like to see you actually signing the okay. Go ahead, Dr. Velasco. Thank you very much, Dr. Velasco. And Pauline?
Finally,
okay.
Okay, and finally, the chair of the ROP working group who has been working on this for several years, Dr. Pearl Tamesis Villanon. And after your signature, there, maybe we can see the document as well. There you go, all 4 signatures on the copy of Dr. Villanon.
Thank you very much to our 4 lady signatories. That was such a display of girl power, right, Pauline? And
correct.
This COVID,
Correct.
this
May we just
COVID-19.
request the Sorry, may we just request the 4 doctors to please pose for a photograph?
That's Dr. Luna and Dr. Pearl Villalon on our end.
And Dr. Jocelyn Eusebio and Dr. Belen Amparo Velasco on our end.
Thank you very much, doctors.
Thank you.
Okay. Thank you very much. At this point, I would like to call back our president, Dr. Belen Amparo Velasco, to give the highlights or key messages that we want all of you to remember from the previous 2 lectures. Let us welcome back Dr. Belen Amparo Velasco. Go ahead, Dr. Velasco, with your summary.
Summarize the recommendations of the consensus. Our topic is retinopathy of prematurity, prevention and screening in the Philippines. So let's start off with the recommendation proper. The population for ROP screening will be all newborns with gestational age less than or equal to 32 weeks. Then all newborns with birth weight of less than or equal to 1,500 grams. Then those babies, next slide, those babies who are 32 to 36 weeks and with the following risk factors: S.T.O.P, S for severe sepsis, T for transfusion of packed RBC within the first 10 days of life, oxygen without the use of oxygen blender, then P for prematurity with unstable course, and of course, next slide, we are we would like to underscore that the use of human milk decreases the incidence of any stage of ROP by as much as 75%. And of course, lastly, next slide, please. The follow-up, okay, usually, I mean, the time of initial ROP screening would be at less than 28 weeks. That would be at about 31 weeks. And for babies who are more than 28 weeks, that would be at 20 days of life. Okay. And lastly, next slide. The follow-up would be depending on what the ophthalmologist has seen during her initial screening. Okay, I think that's all. Thank you very much.
Thank you, Dr. Velasco, for giving your summary. So let me call back my co-moderator, Dr. Pauline Santiago, to introduce the personality who will give the closing remarks for this. Pauline?
Okay, thank you very much, Dr. Bandong. Let me introduce Dr. Margarita Luna, the president of the Philippine Academy of Ophthalmology. Dr. Luna.
Dr. Jocelyn Alonzo Eusebio, President of the Philippine Pediatric Society. Dr. Belen Amparo Velasco, President of the Philippine Society of Newborn Medicine. Dr. Pearl Tamesis Villalon, Chair of the Retinopathy of Prematurity Working Group. Esteemed lecturers, Dr. Victor Zapanta and Dr. Iya Pajarillo, and moderators, Dr. Conchitina Bandong and Dr. Pauline Santiago, officers and members of the Philippine Pediatric Society and Philippine Academy of Ophthalmology, good evening. On behalf of the Philippine Academy of Ophthalmology, I thank and congratulate the pediatricians and the ophthalmologists for successfully signing the 2020 Consensus Statement on Retinopathy of Prematurity Prevention and Screening in the Philippines. May this be the start of a fruitful collaboration and cooperation between our specialty societies for the benefit of our prematurely born infants. We hope to engage the Philippine Pediatric Society in the future to establish other programs that will address childhood problems with vision. We also thank our sponsors, Unilab and Pediatrica, for their support. Please continue to stay safe. Good evening and thank you.
Thank you very much, Dr. Luna, for the closing remarks. And I think we were broadcast live at the Facebook page of the Philippine Society of Newborn Medicine. And at one point, there were about 800 logged on to the site, combined site and Zoom and the Facebook platform. Okay, I think that concludes our S.T.O.P ROP 2020 Consensus Statement on Retinopathy of Prematurity, Prevention and Screening in the Philippines. Thank you very much, Dr. Bandong.
Thank you to everyone. So it's a pleasure working with the Philippine Academy of Ophthalmology and of course with Philippine Pediatric Society. Stay safe, everyone. Good evening, good night.
Thank you, Dr. Santiago and Dr. Bandong. That wraps up our online event, S.T.O.P ROP, the 2020 Consensus Statement on Retinopathy of Prematurity, Prevention and Screening in the Philippines. Thank you very much, everyone, for attending, the heads of our societies, to our esteemed speakers, moderators, panelists, and of course, to our presenting societies and brands, the Philippine Pediatric Society, the Philippine Society of Newborn Medicine, the Philippine Academy of Ophthalmology, and the Retinopathy of Prematurity Working Group of PAO, in partnership with Alagang Unilab and Pediatrica, the pediatric subsidiary of Unilab. Keep safe and healthy, everyone. We salute all of you. Good night.
I think the panelists, all of us will have a picture taking.